just want to say that this is just part of my practice, but it's one of the most rewarding parts of my practice. I'm able to help people in a way in which maybe the dentistry can't. I've had notes come back, you saved my life, you saved my marriage, you know, I can drive now, which, you know, I didn't expect when I first started. How I even got into this was by accident. One of my patients was doing a PhD in neurobiology, and PhDs historically take years and years and years. So finally, you know, what are you doing? I'm going to work in a sleep center. What's that? And what do you mean? And he went on to explain to me obstructive sleep apnea. Didn't really get it. Snoring, of course, I got. And he explained what a CPAP was. And being oral, I said, well, why don't you put it in the mouth? And I really didn't know what I was saying because I didn't know what a CPAP was. But he said, you know, I think there are references to something dental. And he forwarded his notes from a meeting, and I kept these ads, and finally I called the group, the Sleep Disorders Dental Society, and got involved. So that's how I got involved for 18 years. At this point, I am a diplomate of the Academy of Dental Sleep Medicine. This status is a demonstrated higher level of knowledge and expertise within this group. The sleep centers that have fellowships actually send me their fellows, and they're actually side by side with me in my office learning dental sleep medicine as well as dentistry, because they're going to see a mix of everything. I'm a consultant at some of the sleep centers. They need a dentist on staff now to be accredited. Of course, I provide oral appliance therapy, and most importantly, I'm working as a team with your sleep physicians treating you. So this was the society, the Sleep Disorders Dental Society. I thought they would have a secret handshake. It was kind of funny. But in 1990, there was maybe 40 of us. And I would be on conference calls for 2 hours at night. One guy was in Hawaii, all over the country. We're talking about the group and how to promote this. Today, it's an international group, the American Academy of Dental Sleep Medicine, and that's sort of what we're calling it, dental sleep medicine. 2,000 members plus. There's a German group, there's a Japanese group. You have friends that need a dentist in any state. You go to this website, and you can go to find a dentist, and you can look. At least once a year, I go to the main meeting, and I interface with the physicians. This is the main sleep meeting. They have your sleep techs, all the sleep physicians, and the dentists. We dovetail right in there, and we have the physicians attending our meeting. This year it was in San Antonio, brutally hot, but a fun city. We as dentists talk about a lot of different things. There was a presentation about the effects of sleep apnea on the cardiovascular system, on the endothelial lining of your arteries. What about the kids, pediatric dentistry? We historically don't treat them with an oral appliance because their facial jaws are growing. But now we're beginning to say, well, let's get in there and start to treat them. We would like to do research. We talk about the attitudes and preferences, CPAP versus oral appliance. There's a lot of lectures every year on teeth grinding, which is bruxism, pain, and sleep. Some of the dentists have a specialty in the TMJ, and they also have dental sleep medicine as part of their therapies. Here's a whole nother end that we talk about, the socioeconomic impact of drowsiness. Do we have a role as dentists? We sure do. You know, the trucking, the planes, the trains, the ships. What about a guy who's sleeping at a nuclear power plant? And how about tangentially our teenagers and driving? I mean, it's all related. So I'll quote Dr. Simmons, "Dentists can make an enormous difference in society and serve the public in a meaningful way by catching sleep disorder breathing early in the continuum and co-treating with our physician colleagues. We can save more than a tooth, maybe a marriage, by addressing snoring, and maybe a life." So we're thinking of ourselves more globally than just the technician making the plastic chunks. Where did it come from? Some infants have a genetic disorder. They're born with small jaws. For them to breathe, the tongue was sutured out to their lower lip. Then helmets and chin straps were used. Pierre Robin reports the first use of an oral appliance for these infants. Late 70s, surgical advancement of the jaws to open the airway. Right here, these are physicians. They made one of the first oral appliances, tongue retaining devices, to prevent snoring. And it worked great. And it actually works for sleep apnea. Late 80s, you're getting some reports on the oral appliances. How do they work? Obviously, they're used in the mouth during sleep, and they prevent the airway from collapsing. This is your airway back here. The lower jaw is pushed forward, held in place, pulls the tongue forward because the tongue is attached to the lower jaw, opening the airway. You also have a free-floating bone here, stabilizes that. Simple. We've done a number of studies before and after. If you pull your lower jaw forward, the airway does open. Here's the blue, a little more blue here. If you take the other section, the blue, the dark blue, we know it opens the airway. They function in 3 ways: repositioning the mandible, tongue, soft palate, and hyoid bone, stabilizing the mandible, tongue and hyoid bone, and increasing the tongue activity. That also helps keep the airway open. How effective are oral appliances? They work. They're effective. The sweet spot is mild to moderate. Very effective. Severe, it's less effective. However, you can get success. Michael asked me to talk a little bit about this article. This was just published in Respiration. This was a randomized control, oral appliance, CPAP, and placebo. You get a number of people and you put them in one of the 3 groups. Their hypothesis was that oral appliances are as effective as nasal CPAP. Oh, so I loved that article. But I went to get the article because, what have I been experiencing? I mean, they're saying as effective. They started off with 219 patients. For whatever reasons, they're not qualified for this reason or that. 64 started the program. So you have now 3 groups, random groups. One in oral appliance, one in CPAP, one in placebo. What is the placebo? The placebo was like a night guard, just something in their mouth. Their study was very good. They wanted to titrate, which means adjust to the maximum effectiveness of both the CPAP and the oral appliance. The CPAP was titrated. They went through 3 studies. On the 3rd study, you got your optimum pressure. The oral appliance was titrated at the most effective protrusion. Again, you got to move the jaw forward. So that was done like 4 times. The difference was, with the oral appliance, it was ambulatory, so it's something you took home. So one patient only needed 25%. 7 patients needed 50, 12 needed 75% of this total motion. What were the results? The AHI is on the left, which means how many times an hour are you awakening yourself with a desaturation. What did they find? The MAD is mandibular advancement device, oral appliance, before, after. They all went down. They all went down. You started Some of the group was up in the 30s or 40s. Some of the group, most of the group was mild in the 20s, and they went down below 10. This is what I'm finding. This is exactly what I'm finding. This is exactly what our studies show. CPAP is more effective, definitely. The placebo, this was very interesting. You got some effect. Certainly we don't want to make anybody worse. The placebo made somebody worse. Probably pulled the jaw back the other way. I want to go back to this. I don't really think that the oral appliance, as they said, is as effective as the CPAP, even with their data. At the very end, they did some statistical finagling, as I call it. And it's very hard to understand, but I didn't like the way they did that because the graph really shows what it is. And the graph shows what it is. This is my sweet spot. You got mild to moderate, it comes down there. My success is 5 or less AHI. This is from like 10 years ago. Basically, it's the same. This, I think, is a little better with moderate. Severe, I've been doing a little better than 40%. What are the guidelines set up by the American Academy of Sleep Medicine? This is the umbrella group. This is the medical group telling the dentist this is the parameters. Diagnosis, and I believe this should be done before appliance therapy, unless the sleep physician really wants it first, and then you're going to go back for a sleep study with the appliance. And it should be done by the physicians. Indications, certainly primary snoring. The oral appliances work great to reduce snoring. Selected patients with OSA, obstructive sleep apnea, mild to moderate. We know that. We were told that twice with their guidelines. If you can't use the CPAP, obviously, this is an alternative. Whether you're severe or moderate, you should get some treatment, so oral appliance. If any surgical contraindications are applicable. Appliance fitting. I think the appliance fitting should be by a dentist. We know the hard and soft tissues. We know your muscles. We know your joint. We're very adept at taking impressions and tweaking these if needed. Follow-up, most important thing. You need follow-up with the dentist. You need follow-up with your physicians to see if the oral appliance is doing what it's supposed to be doing. We need to see you as dentists, if you have an appliance, at least once a year to look at what's going on, evaluate the appliance. So the treatment objectives is to reduce the snoring, and really obstructive sleep apnea, we want to reduce any clinical signs and symptoms, normalization of the apnea-hypopnea index, and oxygen saturation. The only way to know this, certainly you will feel better, but the only way to know this is with a follow-up sleep study. So when you're coming back, we're updating the progress, changing symptoms, compliance. This is all subjective. Side effects, we're looking at your teeth. We're going to give you an Epworth sleepiness score. We're going to see the examination, the fit, your bite, any muscular or joint problems. And then we're going to say, when is the next time we're going to see you? We'll set that up. Tons of appliances out there. Dozens and dozens, actually. You have 3 main types. One is what we're talking about, mandibular repositionings, MADs, oral appliances. They're called a lot of different things. Tongue retaining appliances. Just approach the tongue. Holds the tongue out. This is where it started. Now we're looking at combination of oral appliance and CPAP. When will that be indicated? If you have tremendous pressure. If we give you an oral appliance, we can move the jaw forward and possibly reduce that pressure. It's a lot of hardware you're going to be wearing.
What did you mean by pressure?
The CPAP pressure.
The teeth or the
Combination therapy, you wear an oral appliance and your CPAP together. And I have some pictures at the end of that. And that could reduce your pressure. But it's a lot of hardware.